This video presentation deals solely with the central nervous system, in particular with the cranial nerves. The peripheral nervous system is covered extensively in a separate presentation. Before we go through the procedure for assessing the cranial nerves, it is important that you remind yourselves of their basic anatomy and physiology. In terms of anatomy, you need to know the origins of the 12 cranial nerves, that is, the location of their respective nuclei and the course of their tracts until they supply their effector structures. The cranial nerves have a variety of functions. In general, some are purely sensory, some are purely motor, others are mixed, and 4 of them have additional parasympathetic component. One simplified way of remembering the origins of the cranial nerves is to think of the numbers 2, 2, 4, 4. This signifies the approximate location of each of the cranial nerves. The nuclei of the first 2 cranial nerves arise from the forebrain, that is the olfactory and the optic. The next 2 cranial nerves are found in the midbrain, that is the oculomotor and trochlea. The next 4 originate from the pons, that is the trigeminal, abducent, facial, and vestibulocochlear. And the last 4 from the medulla oblongata, the glossopharyngeal, vagus, accessory, and hypoglossal. As emphasized earlier, this is a rough guide of their nuclear origin. The trigeminal nerve, for instance, has a sensory nucleus which extends from the midbrain down to the spinal cord to the second cervical level. As we go through the examination of each cranial nerve, I will give you some background information in terms of their anatomy, function, and clinical significance. The 12 cranial nerves are the olfactory, optic, oculomotor, trochlea, trigeminal, abducent, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and the hypoglossal. Let us now assess each cranial nerve in turn. We begin with the first cranial nerve, the olfactory nerve. This nerve has the shortest tract. The olfactory bulb is located inferior to the frontal lobes. It pierces the thin cribriform plate of the ethmoid bone to reach the nasal olfactory mucosa. This is a purely sensory nerve. To examine for olfaction, you need to ask the patient to smell a familiar substance. Firstly, this is to establish whether they can smell it at all, and secondly, to see if they can identify different smells. I'd like you to block one of your nostrils with your finger first of all, and I'd like you to tell me if you can identify this smell.
Chocolate.
Okay. Now, again, I'd like you to tell me what this is.
Soapy.
Okay, so that's fine. And now this one, block your nostril again.
Vanilla.
Good. Use familiar and gentle substances such as vanilla, coffee, or soap. Harsh or noxious smells may cause irritation and may lead to inappropriate perception. Test each nostril in turn by asking them to block the other nostril. As well as testing for olfaction, you may also need to examine the nasal passages with the rhinoscope or your diagnostic kit. Check the nasal mucosa for inflammation, discharge, and obstructions like polyps or tumors. Functioning of the olfactory nerve may be affected, for instance, by head injuries, sinus problems, or in senile anosmia. If unilateral, consider a blocked nostril or frontal lesions. Remember that temporary loss of smell often follows a viral infection, and in some cases recovery may be slow or even incomplete. Also consider Parkinson's disease. The optic nerve, the second cranial nerve. Like the olfactory nerve, This is also a sensory nerve. The optic nerve starts from the retina of the eye and then exits through the optic canal of the sphenoid bone. The nerves from both eyes converge anterior to the pituitary to form the optic chiasma. Here, the fibers from the nasal or medial half of each retina cross over to the optic tracts of the opposite side. The fibers from the temporal half of each retina remain ipsilateral. The nerves synapse at the lateral geniculate bodies in the thalamus, from which the optic radiations emerge and terminate at the visual cortex of the occipital lobes. From here, the optic radiations travel onto the primary visual area of the occipital lobes. Begin the examination of the optic nerve with a general observation of the external features of the eyes, the eyelids, the conjunctiva, and the whole orbit in general. Is there any evidence of exophthalmos or the reverse, enophthalmos? First, assess the pupil size and symmetry. When performing papillary light reaction, remember that the afferent component is the optic nerve and papillary constriction is by the parasympathetic component of the third cranial nerve. Check for consensual light reflex, which is pupil constriction in the eye which is not being tested. If both pupils are large or small, consider if the patient is taking mydriatic or miotic drugs. Senile miosis or small pupils is often observed in the elderly. A small irregular pupil that does not respond to light but with normal accommodation may indicate Argyll-Robertson's pupil. Causes include syphilis, diabetes, and rarely midbrain lesions and multiple sclerosis. A pupil which does not react to light and accommodation is slow indicates Holmes AD pupil, a degeneration of the ciliary ganglion. Now test for visual acuity. Place a Snellen chart 6 meters away from the patient. Test each eye separately to see if the patient is able to read the chart. Can I get you to block the other eye and again try and read the smallest print?
LHTOCNEA.
Fine, thank you. Normal eyesight is termed 6/6 vision or, in empirical measures, 20/20 vision. This means that at 6 meters away, the patient is able to read what a normal person should be able to read at that distance. Alternatively, if, for example, you have 6/12 vision, it means that when you stand 6 meters away from the chart, you can see what a normal person would be able to see standing 12 meters away from the chart. Poor vision is usually caused by refractive errors by which the patient should be able to compensate with corrective spectacles. Ask the patient to read the smallest print and record your findings, both with and without spectacles. To confirm that poor visual acuity is due to a refractive error, you can ask the patient to look through a card with a pinhole to see if this improves focusing. And look at the smallest print and tell me if it appears different. Okay, how is it?
It's sharper.
It's sharper. Can you repeat the same with the other eye now? Block the other eye. And how is that?
It's much sharper as well.
Okay, thank you. Next, check for vision of the peripheral fields. Preferably use a wide-headed pin. Sit opposite the patient with a distance of about 2 feet from each other's face. Start by covering the patient's right eye and your own left eye. Test the visual field of the patient's left eye. Both the examiner's eye and the patient's eye should be fixed on the bridge of each other's nose. Bring in the pin from each quadrant until it comes into view for both parties. This is of course a crude test and it assumes that the examiner's peripheral vision is normal. Remember to take into consideration and to map out the blind spot. This is essentially the optic disc, which is devoid of rods and cones. Whilst continuing to fixate the eyes, slowly move your object from laterally to medially. Tell the patient to indicate when the object first disappears from view and again when it reappears. So block that eye first. Okay. Now when the red pin disappears, let me know.
No. And it's back.
It's back now, yeah? Again, tell me when it disappears.
And it's gone. And it's back.
Now can you block the other eye? And again, let's do the same. Tell me when it disappears and again when it reappears.
It's disappeared. And it's back.
And again.
It's gone. And it's back.
Defects in the visual fields must be defined according to their distribution. If a defect is found near the center of the visual fields, this is termed as central scotoma, and the test should be repeated using a red-headed pin. Lesions involving the optic nerve include optic neuritis, as in multiple sclerosis, pituitary tumors, and infarcts from the posterior cerebral artery. Note that pituitary enlargement, when advanced, often leads to bitemporal hemianopia or tunnel vision. In homonymous hemianopias, which are incongruous, it indicates lesions of the optic tract, and if congruous, the lesion is after the lateral geniculate body. If the macula is spared, it indicates lesions of the occipital lobes. Next, examine the fundi of the eyes using an ophthalmoscope. Become familiar with the instrument and know how to use it effectively. For ophthalmoscopy, you need to have the room light dimmed. First, check for the red reflex. Then look for corneal lesions and opacities such as cataracts or floaters. From about a foot away, shine the light through the eye and observe the red-pink appearance of the pupil. Next, examine the fundi of the eyes. Refer to the use of equipment menu for a full description on how to use the diagnostic kit. Set the ophthalmoscope to +10 diopters to examine the anterior portion of the eye, gradually reduce it to 0 or until the retina comes into focus. Next, examine the different structures of the retina, the optic disc, the vessels, and the macula. Aim your beam towards the center of the back of the patient's head, or about 15 degrees from the line of fixation. The optic disc is located by finding the place where the retinal vessels converge. Assess its borders and color. When examining the optic disc, look for signs of papilledema, glaucoma, and demyelinating diseases. The paler area of the optic cup is located within the optic disc towards the nasal side. If enlarged, consider the possibility of glaucoma. In papilledema, the disc is swollen and the margins are blurred. The cup may not be distinguishable, and it often indicates increased intracranial pressure. Then locate the macula. This is the area of central vision, and it is found lateral to the optic disc. This area should be clear of vessels. The retinal arteries are lighter in color than the veins. Check for tortuous vessels and the appearance of silver wiring, which is produced by distended arteries as they reflect the light. Note any arteriovenous nipping. This is caused by high-pressure artery partially occluding a vein passing underneath it. Examine the retina for hemorrhages, pigmentation, and exudates, signs of hypertensive retinopathy. Also consider atherosclerotic changes to the vessels. In diabetic retinopathy, there will be hemorrhages, cotton wool spots, new vessel formation, dots and blots, exudates, and vitreous hemorrhages. Cranial nerves 3, 4, and 6, the oculomotor, trochlea, and abducent. These three cranial nerves are tested together since they share a common function, that is movement of the eyes. For the purposes of this presentation, we will not distinguish between different lesions of these three cranial nerves. Their nuclei are found in the midbrain and pons areas. The trochlear nerve supplies the superior oblique muscle and the abducent nerve the lateral rectus muscle. The third cranial nerve supplies the medial rectus, inferior rectus, superior rectus, and inferior oblique muscles. It also performs two other functions: innervation of the levator palpebrae superioris, that is the upper eyelids, and constriction of the pupils through parasympathetic components. Begin with observation. Note the level of the eyelids. Is there any evidence of ptosis, that is droopiness of the eyelids? Observe the symmetry and the position of the eyes. Strabismus or squint may become more evident when the affected eye is moved towards the direction of the affected muscle. The patient may be tilting the head to one side in a long-term attempt to compensate. Test for strabismus and diplopia. Ask the patient to follow your finger whilst you slowly move it in front of their eyes, drawing the capital H letter. Make certain that they do not move their head, just their eyes. Ensure that the range of movement is within the physiological boundaries of comfortable vision. Taking your finger too far laterally or moving it too fast will produce inaccurate findings. Before you start, ask the patient to let you know if at any stage of the test they see double. Now, can I get you to follow the tip of my pen? And if at any stage you experience double vision, let me know. Okay, try and follow it with your eyes. Observe for any evidence of strabismus or nystagmus. Fine. How was that? Did you have any double vision?
None. No.
If double vision is experienced, then ascertain its origin. Does it involve a particular muscle or nerve, or a combination? Refer to the tables in the slideshow for a full analysis of these lesions. Now test for accommodation and convergence. Hold an object about a foot away from the patient's nose and slowly bring it closer with the patient fixing on it. You should be able to observe the pupils constricting in order to allow the patient's vision to remain in focus whilst the eyes converge medially. And cavernous syndromes, tumors with artery aneurysms. When assessing, check for evidence of Horner syndrome. Horner syndrome develops as a result of compression of the nerves which arise from the cervical spine via the T1 nerve root. These nerves supply the face and pupil, causing partial ptosis of the upper eyelid, enophthalmos or sunken eye, anhydrosis or dry face, and miosis or small pupils. Cranial nerve 5, the trigeminal nerve. This is a large cranial nerve with a motor and sensory components. The motor nucleus is located between the midbrain and pons areas. The sensory nucleus arises from the midbrain and stretches down to the level of C2 in the cervical spine. The motor component supplies the muscles of mastication, that is the masseter, temporalis, and the pterygoids. The sensory component supplies the skin of the face, the cornea, and general sensation to the mouth. First, observe the patient's face. Note any evidence of asymmetry caused by wasting of the muscles of mastication. Ask the patient to lower and elevate the jaw. Watch for any deviation in the jaw movement. Remember, of course, that common temporomandibular problems will cause jaw irregularities. Ask the patient to clench their teeth and feel the contraction of these muscles. Alternatively, ask the patient to bite down onto a wooden spatula whilst you attempt to remove it. Lesions of the fifth cranial nerve will result in atrophy of the ipsilateral muscles of mastication and, when lowering the jaw, deviation towards the side of the lesion. Now assess the sensory component of the trigeminal nerve. Test with light touch and pinprick. You should also test for temperature sensation if necessary. Ensure that you cover all the areas in the distribution of the ophthalmic, maxillary, and mandibular divisions. Test for sharp and dull sensations using the sharp but occasionally substituting the blunt end of the pin.
Dull. Sharp. Sharp. Dull.
Thank you. You can open your eyes now. Next, test for the corneal reflex using a twisted piece of clean cotton wool. Approach the eye from the side and gently touch the cornea. Both eyes should blink. Finally, test for the jaw jerk. Ask the patient to relax the jaw by leaving a space between the teeth. Place your finger on the patient's chin and observe the reaction of the jaw. Note if the region of the ophthalmic reflex. Remember that while the perception of the corneal touch is via the trigeminal nerve, the closure of the eye is affected by the facial nerve. The facial nerve, the seventh cranial nerve. This is a mixed cranial nerve. It has many components and supplies diverse areas. It arises from the pons. The motor component supplies the superficial muscles of the face, which control facial expression.
Supplies motor muscle, the ossicles, the amount of skin,
or in the facial is the tongue, but only as the sublingual salivary sympathetic supplies the lateral of the facial nerve begins with observation of the patient's face. Look for symmetry of the facial features, such as the wrinkles of the forehead and the nasolabial folds. Observe the eyes for evidence of excessive or deficient tear production. Also, ask the patient if they are experiencing excessive saliva production or suffer from dryness of the mouth. Ask the patient if they experience distorted hearing. Next, ask the patient to perform some active movements which test the muscles of facial expression. Ask them to lift up their eyebrows and then frown, screw up their eyes tightly, whistle, show their teeth, and to blow out their cheeks. Okay, that's good. Can I get you to squeeze your lips together tightly? Again, don't let me pull them apart. That's fine. Can I get you to blow out your cheeks? That's fine. Can I get you to whistle? And show me your teeth? Fine, thank you very much. The taste function is not routinely assessed, but if you wish to carry out this test, use 4 substances: sweet, sour, salty, and bitter. With a cotton bud, touch specific areas on the tongue and check if they have identified the sensation correctly. The patient must rinse their mouth between different tests. With upper motor neuron lesion, only the lower part of the face is affected, whereas in lower motor neuron lesions, there will be weakness in the upper and lower parts of the face. Bell's palsy is a unilateral paralysis of the lower motor neurons. There will be facial distortions such as sagging of the mouth and dribbling. It would also present with a loss of taste, inability to frown or close their eyes, and have excessively watery eyes. It may also affect hearing in the form of hyperacusis. Other lesions affecting the facial nerve include tumors and cerebrovascular accidents. The vestibulocochlear nerve, the eighth cranial nerve. This is a sensory nerve with two components. The vestibular component supplies the vestibular apparatus, which is essentially the balance mechanism. The cochlear component supplies the cochlea, which houses the hearing organ. Let us begin by testing the vestibular mechanism. The patient may have already complained of dizziness, vertigo, nausea, or loss of balance. Part of the balance assessment was also ascertained when posture and gait were observed in the assessment of the peripheral nervous system. Also, during the examination of the eyes, you may have noticed the presence of nystagmus. A good test for assessing the vestibular apparatus is Hall-Pike's maneuver. Position the patient on the examination couch, sitting along its length, so that when you get them to lie horizontally, the head will extend back over the edge of the couch. Explain the procedure to the patient and instruct them that it should be done in a brisk pace. Get them to lie horizontally, allowing their head to hang over the edge. Then turn their head to one side and tell them to fix their eyes on an object for a few seconds. When the patient is in this position, check their eyes for nystagmus. At the end, ask them if they experienced any undue dizziness. You should repeat this test to ascertain whether the nystagmus is sustained or fatigable. Another method of assessing the vestibular system is caloric testing. It involves instilling cold and warm water in the external auditory meatus to try and induce nystagmus. This is normally performed in a test laboratory. Now we test the auditory component of the eighth cranial nerve. A simple but crude method of getting an initial impression of the patient's hearing is to rub your fingers together from some distance to see if you can both hear it. Alternatively, whisper a few words a couple of feet away from the patient's ear. Now, using the tuning fork, assess for conductive or sensory neural deafness. Use a vibrating tuning fork frequency of 512 Hz. Rinne's test makes a comparison between air conduction and bone conduction of sound. In a normal person, sound conducted to the ear through air is better than that conducted through bone. Gently strike or pinch the tuning fork and place its base on the mastoid process. Ask the patient what they hear. They should say a buzzing, vibrating, or humming noise. Then ask the patient to tell you when they no longer feel this sensation. Immediately bring the prongs of the fork close to the ear. They should still be able to hear it. If they don't, this means that something is blocking the transmission of sound through air. Causes of conduction deafness include earwax, middle ear diseases, or loss of elasticity in the ossicular chain. Weber's test assesses the transmission of sound through bone to both ears simultaneously, so that a comparison between the two ears can be made. Place the base of the vibrating tuning fork on the forehead or the vertex of the head. Ask the patient if they feel the buzzing sensation equally in both ears. If the sound is not equal on both sides, this may signify two possibilities: that the weak side has some kind of sensory neural deficit, or the stronger side appears to be so because of a blockage in the external auditory meatus, such as earwax. You may repeat this test, this time with the patient's fingers blocking both ears, to confirm your findings. Make a comparison between your findings from the Weber's and Rinne's test to decide which of the above possibility is more likely, that is, conduction or sensory neural deficit. Lesions of the 8th cranial nerve includes acoustic neuroma, otitis media, labyrinthitis, and tumors, particularly at the cerebellopontine angle. Also consider fractures of the petrous portion of the temporal bone. In sensory neural deafness, consider otosclerosis, Meniere's disease, or trauma. The 9th, 10th, and 12th cranial nerves, the glossopharyngeal, vagus, and hypoglossal nerves. These 3 cranial nerves are normally tested together because of their close associations in terms of origins and functions. Their nuclei are in the medulla oblongata, and they supply mostly areas of the mouth, pharynx, and larynx. The glossopharyngeal supplies the posterior 1/3 of the tongue with taste sensation. Remember, the anterior 2/3 is supplied by the facial nerve. The glossopharyngeal also supplies the mucous membranes of the tonsillar fossa. It also supplies motor to the styloglossal muscle. Its parasympathetic component supplies the parotid gland for saliva production. The descending carotid branch of the glossopharyngeal nerve supplies the baroreceptors in the carotid sinuses and chemoreceptors in the carotid bodies. These sense blood pressure changes and the concentrations of blood oxygen and carbon dioxide. The sensory component of the vagus nerve supplies the tympanic membrane and external auditory structures. The vagus nerve also supplies the aortic baroreceptors and chemoreceptors. The rest of the vagus nerve supplies the many visceral structures in the thorax and abdomen up to the transverse colon. The motor component of the vagus nerve supplies the muscles of the palate, the pharynx, and the larynx via the recurrent laryngeal nerve. The course of this nerve makes it clinically significant, as it can become affected by mediastinal and aortic lesions. The hypoglossal nerve has no sensory function. Of clinical significance, it supplies motor to the intrinsic muscles of the tongue. The glossopharyngeal and vagus nerves can be tested together. Begin by noticing their voice. Is it hoarse? Ask the patient to cough. The inability to create an explosive cough is defined as bovine, which is rather gradual in character. Then ask the patient to open the mouth and with a torch examine the uvula and the tonsillar arches. Ask the patient to say ah. That's fine, thank you. Do the uvula and the arches elevate symmetrically? Does the uvula elevate and deviate to one side? The side to which deviation occurs signifies the stronger side. Therefore, the opposite side is affected by weakness of the palatal muscles. Now test for a gag reflex. With an orange soap, touch each side of the posterior pharyngeal wall just behind the pillars of the fauces. If you haven't got clear access, then depress the tongue with a wooden spatula. Observe the elevation of the uvula and the fauces. Do they elevate at all, and do they rise symmetrically? With the gag reflex, you are testing the glossopharyngeal nerve as the afferent component. The response, or the efferent part in this reflex, is performed by the vagus nerve. The vagus nerve may be affected by lesions in the brainstem, extramedullary lesions, jugular foramen lesions, and with bulbar palsy. Next, assess the hypoglossal nerve. Ask the patient to open their mouth and observe the passively resting tongue on the floor of the mouth. Examine its symmetry, color, and size, and look for evidence of wasting. Observe for a few seconds for the presence of involuntary movements such as fasciculations. An abnormally large tongue is seen in acromegaly, Down's syndrome, congenital hypothyroidism, and amyloidosis. A small or unilaterally wasted tongue, which may also be fasciculating, is seen in lower motor neuron lesions and often in motor neuron disease. Then ask the patient to protrude their tongue. Check its shape, symmetry, and evidence of fasciculations. Does it deviate? If there is deviation, then the stronger side will push the tongue towards the weak side. Finally, assess the strength of the tongue by asking the patient to push their tongue against the inside of their cheek whilst you palpate its strength from the outside. Weakness and fasciculations of the tongue may signify motor neuron disease or any lesion affecting these nuclei or their tracts. The 11th cranial nerve, the accessory nerve. The accessory nerve is a motor nerve. It arises from the medulla oblongata, and it also has contributions from spinal segments C2 to C4. It supplies two somatic muscles, the sternocleidomastoid and trapezius. First, observe the neck and shoulders for symmetry, evidence of wasting or fasciculations. Then, test the strength of the sternocleidomastoid by asking the patient to rotate the head to one side, whilst you apply resistance with the palm of your hand. Observe the contraction of the contralateral sternocleidomastoid and then compare with the other side. An alternative test would be to get the supine patient to raise their head off the bed whilst you apply resistance against their forehead. Finally, test the trapezius. First, observe the shoulders for symmetry. Ask the patient to shrug their shoulders and then push their shoulders down against their resistance. A unilateral weakness of both muscles is usually suggestive of peripheral accessory nerve palsy, most commonly at the jugular foramen. In that case, you may seek for abnormal signs in the 9th and 10th cranial nerves. Bilateral lesions may indicate myopathy or motor neuron disease. We have now completed the examination of the 12 cranial nerves. What follows is a summary of their functions and clinical tests. The first cranial nerve, the olfactory nerve, the nasal mucosa. Test with familiar substances. Examine the nasal passages. The second cranial nerve, the optic nerve, supplies the retina with vision. Evaluate visual acuity. Test the visual fields. Check for light reflex. Perform fundoscopy. The third, fourth, and sixth cranial nerves, the oculomotor, trochlea, and abducent. The muscles that move the eyes, eyelids, and pupils. Observe the eyelids and pupils. Test for pursuit or eye movements and check for diplopia. Check convergence and accommodation. Test the papillary reaction. The fifth cranial nerve, the trigeminal nerve, muscles of mastication and skin of the face. Test sensation over the skin of the face. Check for corneal reflex. Assess the muscles of mastication for symmetry. Test the strength of the muscles of mastication. Test the jaw reflex. The seventh cranial nerve, the facial nerve, muscles of facial expression and the tongue. Check the symmetry of facial lines. Perform active facial expressions. Evaluate taste sensation. Check for lacrimation and saliva production. The eighth cranial nerve, the vestibulocochlear nerve, the acoustic and vestibular apparatus, Assess balance. Perform Hall-Pike's test. Observe for nystagmus. Assess hearing. Perform Rinne's and Weber's tests. The 9th and 10th cranial nerves, the glossopharyngeal and the vagus nerves. The larynx, pharynx, and parasympathetic supply to viscera. Inspect the pharynx. Check voice production. Perform the gag reflex. The 11th cranial nerve, the accessory nerve. The sternocleidomastoid and trapezius muscles. Observe the symmetry of the neck and shoulders. Test the strength of the sternocleidomastoid and trapezius muscles. The 12th cranial nerve, the hypoglossal nerve. The tongue. Examine the shape of the tongue, size, look for fasciculations, and finally evaluate the strength of the tongue.